In clinical practice, we are going to see patients in pain and discomfort and varying different levels of pain intensity, from acute conditions to chronic conditions. Now, as part of our understanding and as part of our rehabilitation process, we have to get across the idea that it is safe to exercise even if you are feeling some slight discomfort. There are some caveats to that we will cover, but we say movement is medicine, and ultimately we want the patient to be moving, exercising and rehabilitating as part of our treatment process. If the patient waits until they are 100% pain-free before they start exercise, they may never actually start exercise. So it's important that we have to get this idea across that you may feel pain, but you are safe. Safe but sore. I know that sounds a little cliched, but safe but sore is a great way that we can say to our patients, it's okay to push into slight discomfort. And actually, that can be really beneficial as part of the rehabilitation process. So when is it okay to work with pain? So in the early phases of a very acute sensitized area, it may be advisable to avoid those movements that are exacerbating the discomfort for a short period of time until things settle down. Once things have settled down, then it's really important that we start to dose appropriately the exercise rehabilitation movements and exercises that we want the patient to do. Remember, less is more, and especially in the early phases, a graded approach to exercise rehabilitation can be very, very important. We want to avoid doing too much too soon. So there are several different things we have to consider when working with patients once we are happy for them to start this exercise rehabilitation process. So firstly, we want the patient to have manageable pain. We want the pain that they're going to push into during the rehab to be manageable, not extreme. We want to be looking at levels of around 4 to 5 out of 10 on terms of a pain scale. We don't want the patient to be in excruciating agony because there's a risk to reward benefit. So we want the patient to have manageable pain. We want the pain levels to be around 4 to 5 out of 10, and we're happy to push towards that. We want the patient to be stable the next day. So they've completed their exercise, their rehabilitation, and the following day, things return back to a normal base level, something that they are used to and are happy to experience with. We do not want extremes. The following day, following your rehabilitation process, we don't want there to be extreme pain, discomfort, and swelling. That would be looking at a contraindication. That would be doing too much too soon. So we want things to be remaining and returning to a stable position after rehab. And we want there to be stable function. We want the patient to be able to move following the exercise rehab and the days afterwards in a normal functioning way. No extremes of discomfort, no extremes of movement avoidance. We want there to be normal function. So those are my sort of caveats for when I'm working with patients pushing into discomfort and pain. So when do we say stop? When does pushing into pain become a contraindication? Because we want our patients to exercise, we want them to move, and in fact, working into pain and discomfort is not necessarily a negative thing. It can actually be a very positive part of the treatment process, giving the patient understanding that they can move safely, even if it is slightly sore, that the body is strong, the body is robust, they have this confidence in movement, they stop avoiding movements, because remember, we want our patients moving. But there is a flip side. So when does it become a contraindication? Well, firstly, if the patient is experiencing extremely severe or unusual pain, that would be an indication that maybe we need to reassess the patient, make sure there's nothing else sinister going on, or we've been pushing way too hard and we haven't dosed the exercise rehabilitation correctly. We've gone too high with our rehab, and rather than starting off low and building up, we've gone in way too high. If the patient is experiencing significant pain and swelling after the exercise rehabilitation movements you've had them doing, that again would be something that we would say, right, we need to stop, we need to readdress this, we need to look at this. if there's been a significantly large change in the patient's function following your exercise rehabilitation, if there is significant severe pain, significant changes in function, again, that would be when we need to back off, stop, reassess. And also if you have one of those patients that is already pushing way too hard. Now, I work with a lot of athletes, and asking them to stop exercising or reducing exercise or changing exercise can be very, very, very challenging. They want to do 110 things at the same time. They push very, very hard. That may be something that you need to discuss with them about tailoring the rehab back to some foundation movements, reiterating less is more, and then gradually building up the tolerance as you move through the process. So those would be my caveats for when pushing into pain could be counterproductive.